Welcome to this explainer on high-yield surgical pathologies and management protocols. We're diving right into case-based clinical vignettes to really bridge that gap between textbook theory and actual clinical execution. Let's get started.
Here are the 5 clinical focuses we're hitting today: lower GI obstructions, colorectal and appendiceal neoplasms, polyposis and rare tumors, peritonitis and ascitic infections, and finally, complex appendicitis management. Section 1. Lower gastrointestinal obstructions, specifically volvulus and pseudo-obstruction. Okay, here is our first vignette. We've got a 44-year-old male presenting with 24 hours of massive abdominal distension and obstipation. He has absolutely no signs of peritonitis. His x-rays shows a massive dilated loop of large bowel projecting toward the right upper quadrant. It looks exactly like a coffee bean. Plus, a contrast enema shows a classic bird's beak narrowing. So what's your best initial step here? Is it observation, a rigid rectal tube, endoscopic detorsion, a laparotomy with manual untwisting, or a Hartmann's procedure? The right move here is option C, endoscopic detorsion and decompression. For an acute sigmoid volvulus, using a flexible sigmoidoscope is key. It allows you to actually pass right through that twist, release all that trapped gas, and immediately decompress the bowel. Now, here's a crucial exam pearl. After you decompress, you've got to leave a rectal flatus tube in place for at least 24 hours. Why? To act as a safety anchor and prevent recurrent torsion. And remember, an emergency laparotomy becomes an absolute mandate if you ever see any clinical signs of gangrene, peritonitis, or dusky necrotic mucosa. Let's look at another scenario. You have a 70-year-old immobilized female post-femur fracture surgery, and she develops this massive colonic distension. Imaging shows her cecum is ballooned out to 11 centimeters. A CT scan completely rules out any mechanical obstruction. She was given IV neostigmine, but it totally failed to achieve decompression. What's the next best step? Decompressive colostomy, laparotomy, diagnostic laparoscopy, endoscopic colonic decompression, or continued observation?
The answer is D, endoscopic colonic decompression via colonoscopy. What we're looking at here is Ogilvie syndrome, a functional pseudo-obstruction, and this is where Laplace's law really comes into play. It dictates that the cecum undergoes the greatest baseline wall tension, so once that cecum expands beyond the 12-centimeter danger zone, spontaneous perforation risks literally skyrocket. Now, neostigmine carries a severe risk of bradycardia, so you have to have continuous ECG monitoring to use it safely. But since she failed that medical therapy, we absolutely must decompress endoscopically before her cecum ruptures.
Section 2. Colorectal and appendiceal neoplasms, looking at anatomical and oncological footprints. Try this one out. Which finding represents the most common primary clinical presentation of a right-sided sequel carcinoma? Is it acute obstruction, cachexia alone, iron deficiency anemia, alternating diarrhea, or pencil-thin stools? You got it. It's C, iron deficiency anemia. And this perfectly illustrates the difference in anatomical footprints. The right side of the colon has a massive lumen and a liquid fecal stream. Tumors there can grow huge, just silently bleeding for months, which leads to occult blood loss, iron deficiency anemia, and severe fatigue. Early obstruction is actually super rare there. On the flip side, left-sided tumors sit in a much narrower lumen with solid feces. They grow circumferentially, creating that classic apple core sign on imaging, which causes early mechanical blockages and those characteristic pencil-thin stools. Knowing that, what is the exact standard oncological operation for removing a curable, non-obstructed sequel adenocarcinoma? Segmental resection, excision with ileostomy, standard right hemicolectomy, extended right hemicolectomy, or subtotal colectomy? The standard here is C, a standard right hemicolectomy. You need a wide formal resection from the terminal ileum all the way to the hepatic flexure. This absolutely mandates high ligation of the iocolic and right colic arteries right at their origins from the superior mesenteric artery. This ensures you get complete clearance of those regional lymph nodes. Now, you only step up to an extended right hemicolectomy, which sacrifices the middle colic artery, if the tumor is further along in the transverse or splenic flexure. Speaking of location, what about rectal cancer? Down in the narrow confines of the bony pelvis, rectal cancer carries a uniquely high local recurrence trap. This completely changes our management, mandating a multimodal approach. You need preoperative neoadjuvant radiotherapy to shrink the tumor, followed by a total mesorectal excision, or TME. This surgery requires incredibly sharp, bloodless dissection within what surgeons call the holy plane. You remove the rectum entirely wrapped in its mesorectal fascial envelope. Doing this protects those crucial pelvic nerves and prevents local recurrence down the line.
Section 3. Polyposis and rare tumors, covering genetic syndromes and aggressive lesions. Let's look at this case. A 22-year-old male presents with intermittent abdominal pain, dark stools, self-limiting bowel obstructions, and brown to black perioral macules. He also mentions his father had colon surgery at a very young age. What's the diagnosis? Melanosis coli, malignant melanoma, Peutz-Jeghers syndrome, Cowden syndrome, or FAP syndrome. It's C, Peutz-Jeghers syndrome. The really crucial distinction to make here is between hamartomatous polyps and other types of colon pigmentation. In Peutz-Jeghers, large hamartomas act as lead points for transient intussusceptions. That's what's causing his transient obstructions. And while the polyps themselves are benign malformations, these patients carry a severely elevated lifetime risk for extraintestinal cancers, like breast and pancreatic. Melanosis coli, on the other hand, is completely benign. It's just a dark brown discoloration of the colon caused by chronic senna or anthraquinone laxative abuse. Let's rapid-fire some high-yield tumor pearls. First, abdominal wall desmoid tumors. They don't metastasize, but they are incredibly locally destructive, requiring wide surgical resection with negative margins, and they are highly recurrent in FAP patients. Next, if you're looking for a primary gastrointestinal neuroendocrine tumor, the vermiform appendix is actually the most common site. And finally, pilonidal sinuses. Usually you find these in the sacrococcygeal cleft, but surprisingly they can develop in the interdigital webs, literally between the fingers, of professional barbers as an occupational disease.
Section 4. Peritonitis and acidic infections, differentiating primary from secondary sources.
A 6-year-old child with nephrotic syndrome suddenly develops a board-like, rigid abdomen. A tap of the cloudy acidic fluid reveals a monomicrobial infection of Streptococcus pneumoniae. Is this tuberculous peritonitis, biliary peritonitis, primary spontaneous peritonitis, secondary peritonitis, or intussusception?
The correct answer is C, primary spontaneous peritonitis, or PSP. This is a critical distinction matrix right here. PSP occurs without any structural breach. In this little girl, urinary loss of immunoglobulins allowed bacteria to transmigrate straight into her ascites. It's strictly monomicrobial, no free air on imaging, and it's treated simply with IV antibiotics. Secondary peritonitis is a totally different beast. That's driven by a burst appendix or a perforated ulcer. It's highly polymicrobial, you'll see free subdiaphragmatic gas, and it demands an absolute emergency laparotomy.
Now, this primary infection mirrors itself in adults, specifically those with decompensated liver cirrhosis and tense ascites. But the bacterial footprint changes here. It's predominantly driven by E. coli. You diagnose spontaneous bacterial peritonitis when the acidic fluid shows an absolute neutrophil count greater than 250. Recognizing this is huge because it avoids an unnecessary laparotomy. Putting a severely cirrhotic patient under the knife for this carries a massive, highly lethal perioperative mortality risk.
Section 5. Complex appendicitis management, focusing on perforations and phlegmones.
All right, when the appendix ruptures and floods the abdomen with a polymicrobial mix, your surgical technique has to adapt to manage all that gross contamination. If a patient has generalized purulent peritonitis from a perforated appendix, what is the most appropriate management configuration? Lavage and drain alone, appendicectomy with primary wound closure, appendicectomy and drain with the skin left open, laparoscopic appendicectomy without lavage, or deferring surgery for 6 weeks? You want option C. You perform the appendectomy, leave a drain, but you must leave the skin open. There are exact steps to follow here. Use a lower midline laparotomy so you can visualize all quadrants, do a formal appendectomy, use copious warm saline lavage, and place an organ space drain. But most crucially, you purposefully leave that superficial skin incision entirely open to heal by secondary intention. If you try primary closure in a grossly contaminated field like that, you are looking at a near 100% risk of severe wound infection and fascial dehiscence.
Let's leave off with this thought. If a ruptured appendix gets walled off into an inflammatory mass, we initially treat it conservatively, without surgery, using the Ochsner-Sharon regimen. But when you successfully treat that mass and the patient gets better, why is a 6-week interval appendectomy absolutely mandatory? Well, because in up to 20% of older patients, hiding right beneath that inflammatory scar tissue is a primary underlying appendiceal neoplasm, like an adenocarcinoma or carcinoid tumor that actually initiated the rupture in the first place. Catching it early could literally save their life. Makes you think twice about successful conservative management, doesn't it?